Hello. Well, I'm going to try to summarize what everybody already has talked about, and this is about amputation prevention, so we got to learn how to prevent, and in order to prevent, we need to diagnose. I have no disclosures, unfortunately, and these are the heart of women. Let's start with this statement. LEG symptoms are not adequate to identify patients with PAD who are at high risk for cardiovascular events. The reason I started my talk with this is because we've been talking a lot about how we are going to focus our treatments based on symptoms. By the way, I didn't make this statement. This was Alan Hirsch in atherosclerosis. So based on that, I'll leave you with this quote by Mark Twain: whenever you find that you are on the side of the majority, it's time to reform. So, peripheral arterial disease, we already know, is underdiagnosed. There's 10 million people with PAD, we're only diagnosing a quarter of them, and we're only treating 400,000. So no wonder we have the problem we have. Why shall we get better at diagnosing it? Well, already everybody has repeated this 1,500 times. There's 185,000 amputations per year, approximately in the US alone. Patients with intermittent claudication have a threefold increase in mortality and cardiovascular causes, and patients with PAD have a 10-year drop in life expectancy. So who's at risk? Anybody who has diabetes, who's younger than 50 and either smokes, has high cholesterol, high blood pressure, or hyperhomocystinemia. Patients from 50 to 69 years of age who either smoke or have diabetes. Anybody who's older than 70, or patients that present with leg symptoms with exertion or ischemic rest pain. You have patients who have abnormal leg pulses and examinations, and patients with coronary disease, carotid disease, or renal artery disease, which are all atherosclerosis. This slide has been already presented. What are the risk factors? We already know: smoking, diabetes, high blood pressure, high cholesterol, and some of the more novel risk factors. And here's the importance of changing these habits. We can see how people that continue to smoke has worse survival, of course, than those who quit. As we have founded on diabetes, you have more risk of having PAD than patients with normal glucose or patients with impaired glucose tolerance. Now, when you combine diabetes with an abnormal ABI, either less than 0.9 or more than 1.4, diabetes doubles mortality compared to patients without diabetes or patients with intolerance to glucose. Sorry. The prevalence of PAD increases with age. We already know that. Also, it's gender-based. Until the 84 years of age, it affects us more than women. And then after that, because we couldn't tolerate women anymore, we die, and then it's more prevalent in women. In terms of ethnicity, it's more frequent among African Americans and then non-Hispanic whites. And when you talk about the general population, you're going to find, and this was actually an interesting study, they went to regular primary care offices, and when they did ABIs, they found that 30% of patients that were not being diagnosed were all of a sudden diagnosed with having PAD. Now, why is this important? Well, because the earlier we diagnose, the better it's going to be off. Patients with even asymptomatic PAD at 10 years, you can see there's a 25 to 30% increased mortality compared to normal subjects. So, and these are the people that we do not diagnose. These are the people that unfortunately get to present too late. These are the people that come in with the ulcer and end up with an amputation. These are the people that are going to make us be able to be successful in amputation prevention, because if we diagnose them early, they'll be fine. The cardiovascular risk, of course, increases with decreases in ABI. The worse your ABI, the higher your risk for cardiovascular events. Now, talking about critical limb ischemia, Dr. Adams already presented this on the other side, just to repeat that, but this is an important study because it's 19 studies compiled looking at 6-month outcomes. And you're going to find patients with CLI have 35% of them are alive, but already had an amputation 6 months out. 20% of them are dead. And 45% are alive, but do not have an amputation, thankfully. We got to do better. What factors increase the risk of limb loss in patients with CLI? Diabetes, severe renal failure, patients with severely decreased cardiac output, those that have congestive heart failure with low EF, patients with vasospastic diseases, including Raynaud, and of course, those who smoke. What other factors? Factors that increase the demand for blood flow in the areas of microcirculation, which are infection and skin breakdowns. So that's why we have to include wound treatment and our infectious disease colleagues in the management of these patients. Now, when we talk about risk factor modification, everybody has talked about this. Smoking cessation, treat high blood pressure, treat cholesterol, diabetes, and use antiplatelets. And as I just added, wound care and infectious disease people. Smoking cessation is a Class 1B recommendation for patients with PAD. This is according to national guidelines from 2006. Antihypertensive meds, patients with PAD should be treated to a target blood pressure less than 140/90 is a Class 1A indication. If there's diabetes or chronic kidney disease, you should be more aggressive and treat to a goal of less than 130/80. And I think Dr. Diaz touched on this yesterday about beta blockers. According to the 2006 guidelines, they are effective and not contraindicating and have a Class 1A indication. This is talking about ACE inhibitors. This is the ABCD trial. And you can see here that even among patients that have a very poor ABI, these are critical limb ischemia patients or severe PAD patients, if they're treated with an intensive regime, they do much better than those that are treated with mild to moderate intensity, which unfortunately happen to be most of the patients in the real world. Lipid-lowering therapy, Class 1B indication for all patients with PAD to an LDL of less than 100, and I'm sure that that's going to change as time goes by. The LDL less than 70 is a Class 2A level of evidence B. In terms of diabetes, proper foot care, skin lesions, and ulceration should be addressed urgently. And Dr. Scott talked about this earlier. It's a Class 1B indication, and to treat diabetes to a goal of hemoglobin A1C less than 7% was a Class 2A level of evidence C, which I'm sure is also going to be changing soon. Antiplatelet therapy. Aspirin should be used in patients with PAD. Is a Class 1A indication to decrease the risk of MI, stroke, or death. And Plavix is an effective alternative to aspirin, has a Class 1B indication. Now, when we put all that together with supervised exercise regimes, hopefully we will achieve amputation prevention. By all means, keep your enthusiasm, but let verification be its constant companion, and I'll end my talk with my most precious treasure. Thank you very much.